All right, good afternoon, everyone, and we start recording. This is the third session for the carotid review on VSAB 5. So let's go and start. But Sam, you want to start first question?
Yeah, okay, let's go.
Okay, let's go, Sam.
A 75 years old man presents with an episode of right hand weakness
Okay.
and is found to have 70% left carotid stenosis. 3 days after admission to the hospital, he undergoes left carotid endarterectomy. And after he emerges from general anesthesia, he has recurrent right upper extremity and new right lower extremity weakness. In addition to surgical re-exploration, the most important initial maneuver in the operating room is
Okay,
so
Sam.
yeah, a 75 years old man with symptomatic right side yes, right side weakness, so left carotid disease, symptomatic one, underwent surgical intervention and recurrence post-op or signs of stroke post-op immediately.
You still, let me see. He emerged from general anesthesia. He's still in the war. Okay.
Yeah,
He just emerged. He's not in recovery. He's not in the floor. It's
yeah,
different. And this
yes.
is a very common question. I'm telling you 100%, guys, you can get this question in the exam. This is very, very
Mm,
common question. You always get in the exam. And it's a very good practical point. What are you going to do? So you just patient wake up from the surgery, from anesthesia, so from resuming under general anesthesia.
mm,
And then he cannot, you did the left carotid and now he cannot move the right side. So he got a stroke.
yeah,
So what first you do? You know, they always tell you go and explore him right away. Okay, that was they want to do here. You know, that was they did. This is
yeah,
really is a teaching, you know, all the time, you know, and I do it a bit differently because I have an access because why you want to do explore right away? Because you want to rule out any thrombosis in the carotid artery, right? Or flap or something like where you have to blame yourself first because before you say it's a distal embolization, because it could be one of two things. Could be either thrombosis or flap in the area of surgery, or maybe you embolize, right? But
no,
always when you have a problem, right, surgery is the first thing you blame yourself. So you want to be sure first your surgery is fine before you go out, you know, further.
sure.
So they want you to go and explore to be sure that the artery is not thrombosed. Again, this is, but now, like, because I mean, it's different from place to place. If you work in a small hospital, I think this is the best way to do it. But if you have like a very access to the ultrasound machine, I will get ultrasound machine right away if I have an access, because you don't want to delay, you know, because now time is important. And I do with Doppler and look with the ultrasound with the duplex. If I find the artery is open, no flap, then I go from femoral artery and do an angiogram to look if any distal embolizations, you know. This is, but for the books, this is the practice. But for the books, or you don't have an immediate access to the ultrasound machine, then the best way to open and look. And then you're going to do one of the things after you open, okay?
Okay,
And I think I have one case like that after you were with me, and exactly what we did. We get an ultrasound. I look at the surgery, was nothing, was beautiful. And that talked to me was no flap, no thrombosis. We did an angiogram, was a distal embolization. We went there to give TBA and patient did fine. But again, if you don't have a quick access, the best way, the safest way, open the patient. And after you open, what you do? This is the question. So you open, now what you do, okay?
okay.
So this is a full option you have.
Mhm. Intraoperative duplex ultrasound if the carotid artery is not thrombosed.
Okay.
Yeah,
So
okay,
there's the first thing you check the pulse. If the artery is
sure.
not thrombosed, you know, then the other problem could be flap. And a flap, you
Yeah,
don't want to open to look for a flap, you know. The only time you really open the artery if you have thrombose. If thrombose, then you have to open right away. If the artery has a good pulse, then you have to rule out flap. Unless if you don't have ultrasound, again, then you open the artery. If you have an ultrasound, the best way to get an ultrasound and check if any flap, you know, there.
no,
Why is that? Because the ultrasound is more accurate than surgery, because the flap could be dynamics, you know, like it open and close with the blood flow. And this is very hard to see it if you open the artery, you know, but with the ultrasound, it will be more accurate. But for some reason, if you don't have an ultrasound, then yes, go and open the artery, look inside, and anything you see, if you find it loose, take it out, you know. Okay, next thing.
Injection of systemic tissue plasminogen activator. Oh, we
TBA.
just finished the surgery, so it's not
Right.
indicated, I think.
Right. You can give it local if you think it has a embolization.
Yeah.
You know, you give it local, but not systemic. Not systemic. Okay.
No.
Okay.
Injection of systemic abiximab.
This is antiplatelets, very strong antiplatelets.
Yeah.
Again, systemic will not work. You know, you just had the surgery, and SAB mixab doesn't work. Antiplatelets will not work in this situation. You know, so this is not a good idea. Okay.
Disassembly of the carotid closure and replacement of a greater saphenous vein patch. No, I don't think.
No, doesn't make sense. Why you need to take it? And it's not a problem with a patch or vein or whatever, you know. So it's not your issue. I mean, it's not the problem. The problem is not here. So that will not help, you know. Okay.
Or resection of the prior site of repair and replacement with an interposition graft. Also,
that's not. Yeah. So again, so the best way is I think number 8.
Do ultrasound. Yes. Okay.
Yeah. So again, as a practical, so patient happen, you open him up right away. You put your hand, you feel a pulse, you know, get an ultrasound. If there's no ultrasound, you know, then you can open and look. But most of you have to have an ultrasound. I mean, if you don't have an ultrasound, you have sometimes, you know, to look. But the most amount you need to do in terms of angiogram. If the problem is not local, if there's no flap and there's no thrombus, then you put a needle through the carotid. You go through the camera. You don't have to go through from the femoral artery. You put a small sheet, you put small cannula, and you inject and do intracranial angiogram to look for distal embolization. Okay.
Okay.
But if you don't open, for some reason you have an ultrasound and you do ultrasound, looks no flap, no thrombosis, then I go from the femoral. Patient still on table and then I go from femoral artery. I go all the way selectively, you know, cannulate the left common carotid artery and do intracranial angiogram to look for that. So you need to do the angiogram. So the first thing you look at surgery site. If there's no problem, look distally. Okay.
Okay.
So even so, this is what you need to do, and then it depends what you find distally. Then you decide to go and do TBA or do like, you know, retrieval of the thrombus. You know, it depends what you find. But this is the way we do it. If it's in the recovery, it's better to do an ultrasound. You know, because it's not to go book the OR again and get anesthesia and everything take too long time. So I think in the recovery, if this happened, like patient's fine, left the OR in recovery, they call your nurse, oh, patient had a stroke. Then the best way in this condition, do an quick ultrasound. If the carotid looks fine, send him down to the angio suite to do a CT, to do an angiogram, you know, or you do a CT. Why do CT? Maybe has intracranial bleeding, you know, so you have to rule it out because some people, they get intracranial bleeding. So if the ultrasound is negative, I'll send him right away to the CT to rule out bleeding. If CT is negative, then we do a carotid angiogram and try to pull out the thrombus. Okay, so this is the way we manage this one. So in the OR, open right away. In recovery, I think you have a time to get an ultrasound. If for some reason you don't have an ultrasound, then take him back to the OR and again do the same things, you know. But if the carotid no problems, then next thing to look for intracranial bleeding and for distal embolization. Okay. Any questions? Because it's an important subject, this one here. No? All right. Let's move to the next question. Oh, Amjad, you want to take this question?
Yes.
All right, let's do that.
The maneuver that would be least helpful in high distal exposure of internal carotid artery. So least helpful maneuver for distal exposure.
Okay, so let's see what they're asking here. What they're saying that, you know, you have a high bifurcation, right? So if you have a high bifurcation, what maneuvers we have? A couple of things you can do them, you know. I mean, luckily we don't see them quite often, but you know, So, you know, a couple of maneuver you do, one or two, give me like one or two maneuver you do. If you have high, but we don't have to know all of them.
Okay. Cutting off the posterior digastric belly muscle.
Yeah. Yeah. This is
ligament.
Very common. Correct.
And nasal intubation.
Yeah, nasotracheal intubations. Because give you more
maxillary
space. Yeah.
Yeah.
If you want
Maxillary
to go, okay, let's go
subluxation.
through three of them and tell me what you think. So the first one, nasotracheal
Okay.
intubation, yes, is one maneuver, especially if you know
Yeah.
ahead of time. You know, of course, you know ahead of time. You're not going middle of the case. You're going to take it and put it, you know. But ahead of time,
Yeah.
if you know a patient has high bifurcation, maybe it's better to start with the nasotracheal intubation. You know, so you can do
Yes.
the jaw dislocation. You know, if you have to do it. Okay. Second things,
Division of occipital artery.
what do you think
I
that will
don't-
help?
No, I think it's away.
Not
يعني
really,
from,
Amjad. No, if you scrub with me, I can show it many times. I show it to the guys, you know. You can see occipital artery cross the internal carotid, you know. And if I want to go higher, you know, many times I clamp this artery. I divide it because it's cross the internal carotid, you know. The only thing I don't like it to do it quite often. The reason why is it's good collateral. If you have internal carotid occlusion, it's good collaterals, you know, so ophthalmic arteries. So you don't want to divide it, but you know, but sometimes
Okay.
if you have to that, you can divide it. So this will help you because again, you can see it in the surgery. Remind me one time if we do a carotid to show you, you can see it. It's cross the internal occipital artery. So it will help. If
Okay.
you divide it, will help you to go really higher. So this is one of them. Yes. Okay. Next
Okay.
one.
Division of posterior auricular artery. Also
This is a
another
bit
branch
difficult.
of external.
Yeah, but this is go behind. Okay, go behind
Yeah.
the ear, right? So
The
it's
ear,
far
yeah,
from you.
yeah.
So this will not
Yes.
help. No, it will not
Yes.
help. Okay. Next one.
The section along the posterior aspect of carotid gland.
Okay.
Uh,
I mean, you just go a bit higher. I think this may work. I mean,
uh-huh.
it's not a very good maneuver, but I see some people, they make incision, they go behind the ear because they dissect more part of the gland. I don't know. It may help. I don't know. I never did this one. So let's see what other option.
Division of stylopharyngeus muscle. So yeah, I think this is to release all muscle attachment to styloid process.
Yeah, some people even they resect the stylus process, you know. But again, if reality, the only thing really help a lot, divide the digastric muscle. This is help you a lot, and the occipital artery. I think this is to really get you high. I did that a couple of times. I never have to do any of the other, like nasotracheal intubation, posterior aspect further. I didn't have to do any of them. Luckily now you don't see this problem because if it's high, you just go with a carotid stenting now. So I don't think you're going to get this issue. But my advice, if you're doing it and you see high, the first thing, start with the digastric muscle, get it there, divide it, and occipital artery. And I can tell you 95% or more will be more than enough. I mean, I did a lot of carotid, you know, I don't know how many, but I never did dislocation. I never even saw it. I don't know how they do it. We never had to do a dislocation. Always, the other trick, what you can do is really, we did that a couple of times also. You see where the carotid body, you know, the carotid body, the tissue there, you can divide between two clamps. When you divide it, because this holds the bifurcation up. So you get two hemostat and you divide the carotid body area, you know, the nerves there between the internal and external, all the tissue. And then when the moment you divide it, the whole bifurcation, you can pull it down, you know. The only thing you have to divide between two clamps because this is very vascular, it'll be a lot of oozing, you know. So all this tissue between the internal and external carotid artery, you divide between two clamps and you cut them. And then once you do that and you ligate them, the bifurcation will come down very, very easy, you know. So this is the three most common maneuver will help you to get to the bifurcations. I think that's all. I don't know if any other maneuver, guys, somebody has any idea, somebody has to add or any questions. But this is really the most common maneuvers. All right, what else? I think that's enough. All right, let's go to the next one, 33. Who's here? Muhammad is not here, Muhammad? Muhammad ما هنا. طيب أحلام. Can I say أحلام? How are you, أحلام?
I'm fine, thank you, sir.
All right, let's go and have this question, Ahlam.
Okay, if selective shunting is employed during the carotid endarterectomy, shunting is indicated when?
Okay, so what they now, you see, with the carotid, shunting is a very controversial issue. Some people, they don't shunt. Some people shunt all the time. Some people do selective shunting. The incidence of stroke is all the same. It's no different. The reason why we don't have a consensus is which what to do. So they left it up to the, even if you go to the guideline, the shunting, they said it is to the surgeon preference, you know, if you want to do selective or non-shunting or, you know, but whatever you have to do it all that, you know, like within a criteria. So if you decide to do selective shunting, then you have to follow up criteria, like when to shunt. And this was the question. If you decide to do selective shunting, when to shunt, okay? Let's say one by one, we're going to do.
Okay,
First one,
carotid endarterectomy is performed under regional anesthesia.
do we need to shunt in this case? It's local anesthesia, right? So patient is
No.
awake. So
No,
we
no,
don't
no,
need
we
to shunt
can't
because, I mean, we don't need to shunt unless if we, you know, unless if patient develop a symptoms, right?
Yes.
But if a general anesthesia, a regional anesthesia, then we can tell from his symptoms, okay?
Yes.
So if the general anesthesia, I mean, the question is tricky because shunt is not is indicated when carotid is not complete wrong because you may need it because the patient develop any sign of, you know, aphasia, you know, become restless, weakness, then you have to shunt him, you know. But what they try to say here that if under general anesthesia, you have something else to watch, you know, regional anesthesia. So, so this is not good question, but this is wrong, yeah. Okay, next one.
The carotid stem pressure exceed 55 millimeter of mercury. I think 35 or 40.
40 and above is acceptable. So 55 is good. So if you have 55, you don't need to shunt, right? So when you have 55, is shunt indicated? No. So this is wrong because they said what the shunt is indicated. So indicated if the pressure less than 40 to 35, but here 55, so you don't need to shunt here. So this is wrong. Okay. Next one.
Alpha and beta waves slow and overall AEG amplitude decreased by 50%.
All right. This
one,
yes. Yeah. Yes, we used to do that, and you know, you have different way to monitor the brain. One of them is to do transcutaneous TCBO2. One of them to measure the pressure, and one of them is to do a continuous EEG during the surgery. And this is really the way I used to do when I was in the state. We used to do that. So we have a technician with us in the OR, and we're doing continuous and EEG. If we see any alpha and beta wave decrease than 50% is the incidence to go and with a shunt, you know. So so it's a nice, you know. I didn't see it here, but I saw it before. So any decrease in the waveform less than 50% is indication to go and shunt. Yes. Next one.
Cerebral oximetry in the contralateral hemisphere decreased by 5 to 10%. I think more, not 10%.
It's correct. This is more than 10%. Should be at least 15%. So this is also is wrong. You know. Last one.
Transcranial Doppler shows mild decreased velocity in the ipsilateral middle cerebral artery. No. So because I will go with C. Yeah.
Because a mild decrease. If it's like severe decrease, yes. If you see the transdopa shows severe decrease in the velocity in ipsilateral, it is, you know, it is then. But you see, all those signs is very soft sign, you know. The reason why, even with a selective shunting, you can still get a stroke because stroke is a very complicated process. It's not like simple as we think. Because if this is all criteria is correct, we should get 0 stroke with the shunting. But we're still getting same idea, same almost percentage, about 2% even with the shunting. But at least you have some criteria to follow, you know. I usually follow up the selective shunting, but I'm very liberal with the shunting. Anytime I have any doubt, go with the shunt. It's better to be safe than be sorry, you know. But again, it's not, even if you shunt, people get still stroke for many reasons. First, the shunt itself can cause a trouble. You can cause an emboli, you can cause a dissection. And second thing again is the stroke pathology is not only decreased blood flow. Sometimes the change in the blood pressure can cause a stroke, you know. So like a patient hyper and then become hypo, then hyper, then hypo, you know, during the surgery, this fluctuation in the blood pressure can cause a stroke. So really the process of stroke is not well studied, and until now we don't know exactly, because whatever we do, we still get almost the same number of stroke. But again, it's nice a guideline to follow if you decide to go with the selective shunting. Some people, they do shunt all the time. They said, okay, it's being safe, but again, the shunt has its own problems. So I think it's not a good idea. Not to shunt at all. Some people, they do that, but they have to be quick. And mostly it's work when you do an inversion technique, because it's very quick and you don't have to do a patch, because patch takes some time. So you do an inversion technique, even under general anesthesia, you can do it without shunt because it's very quick. You just cut the plaque in 10-15 minutes, you're done. So this is time people who don't shunt at all. And some people go with the general anesthesia again. They under anesthesia, if they have any symptom, they go on shunt. So this is the way we decide to shunt or not. Okay.
Okay.
All right. Let's go to the 34. Who is here? Muhammad's not here still. Maybe he's stuck somewhere. Until Sam, I went back to you.
Yeah. The lesion depicted in the figure can be associated with germline mutations in this succinate dehydrogenase complex, subunit D, SDHD gene. Genetic testing should be performed preoperatively with concurrent familial screening in the presence of. So
Okay.
we are talking about.
Let me tell you what they're talking about first. Let's talk. Forget about the gene name. What we have here in the picture.
This is a carotid body tumor.
Body tumor, right? So the question is very simple. I mean, forget about this long name. They're going to tell you when you do genetic testing when you have carotid body tumors.
Okay.
Like patient has a carotid body tumor, we don't do genetic testing for everyone.
Yeah.
The only time we do it if we have really bilateral or familiar, or he has a concomitant, paraganglioma. Then we think about familiar, But if it's just sporadic, single, then we don't do it. But if patient has bilaterals, or he has paraganglioma somewhere else, then you think about, genetic disorders, then you send it for genetic, This is how we decide, So let's go about these questions and sorry. And let's see what the answer said. Let's start first one, the Sam.
Yeah, Champlain 3 tumor.
So Champlain 3 tumor is related to the location, right? There's nothing to do with single or bilateral or something. So already nothing to, it's not a guideline for the genetic workup, right? Okay.
Age older than 50 years.
Well, I'll tell you what the problem is this one. Usually, carotid body tumor, you see it in the old people, because it takes a long time to grow up. So if you see it in young people, then it's like anything you see, any disease, vascular disease, you see in young people, you think it's some genetic or some underlying problems. Anything you see in all people, you expect it to be normal. So really, when you see it in age 50, you don't have to say genetic, but like 30 years old or 20 years old and it has a carotid body tumor, this should be trigger your brain that, we may have a familiar, paraganglioma, and then we have to do genetics. So older than 50, I don't think is a good choice.
Okay. Yes. Unilateral involvement.
Not also, really. Yeah. Because usually if you have bilateral, you think more about familiar, If you have bilateral, you have multiple lesions, multiple level, then you think, but just single unilateral, 50 years old, then we see it all the time in our clinic. We don't do genetic disorder orders, or genetic testing. Okay.
Yeah. Positive MIBG scan.
Okay. This MIBG just if it's active or not active. So also nothing to do with the familiar, So metachronous. You know what metachronous means? Metachronous, that means somewhere else. So you have paraganglioma somewhere else.
Yes.
So this is usually.
I will choose this one. Yes.
Yeah. So again, so the time is like patient has like a pheochromocytoma and carotid tumor, then yes, you think, oh, we have something for genetic testing, You have bilaterals, young people, family history, like his sister also has carotid tumor. So all this trigger your to go and send for genetics. But just single, unilaterals, old man, I will not do it. Young person, family history, paraganglioma somewheres. I think I will send it for genetic disorder testing. All right.
Okay.
All right. This is, it's just a question you have to remember. Oh, I think the incidence, how much incidence? Let me see, is 25%. You see, 75% are sporadic, 25% could be familial disorder. So usually multifocal tumor. So it was a paraganglioma, pheochromocytoma, but the family history. So all the things trigger you that he may have a genetic disorders, and you have sent him for genetic testing.
السلام عليكم دكتور.
يا هلا محمد، وينك ضايع؟
هلا والله.
نعطيك سؤالين ورا بعضهم هذا.
يا السلام عليكم.
الله يعطيك العافية.
الله يعطيك. هلا.
All right, let's get this question. It's not very fresh.
Yeah, okay. So use of autologous bovine pericardial or synthetic patch for arteriotomy closure following traditional carotid endarterectomy is associated with.
Okay, they're talking about before you go.
Closure. Yes.
The patch closure, is it recommended or not recommended?
Yes, for endarterectomy, yes, it is recommended.
Why we do it? Why is that? Even the primary closure is faster. What the study showed? If you use a patch, what do you decrease?
Restenosis.
Correct. And what else? Also, even they showed some study decrease the stroke rate.
Rate, yes, stroke rate.
Yeah, stroke rate and the stenosis, but mainly it's restenosis.
Yeah.
I mean, the good thing is that the majority of restenosis are asymptomatic. The reason why people they don't come with a problem. So people who do primary closure tell you, oh, I'm doing it for 100 patients, nothing happens. But because you don't study your patient, but if you study them, you see majority they have restenosis. But luckily, as most of restenosis are asymptomatics, So there's no, even now, it's a guideline that if you're going to do endarterectomy, it is recommended to do a patch angioplasty. The only time you don't do it if what?
If the carotid is very
big,
it's very dilated, aneurysmal.
Not aneurysm, it's big. Sometimes you go see the artery like 5-6 millimeter big, especially men, not female. Female, almost all of them. And if you do an inversion technique, then you don't need a patch. Yeah. So if you do an inversion technique, you're used to that, you don't need a patch. But if you do normal carotidectomy, then you have to use a patch, especially in women. Sometimes you go there, maybe like 1 or 2%. I didn't put a patch because I went there, the common carotid like 7 millimeters, big artery. So there's no reason really. So I just put the primary closure. But you have to be careful because studies showed that the primary closure associated with more increased risk of stroke, increased risk of restenosis. Okay. So let's see what they said here. What they said. So the patch is what cause? Let's go one by one.
The A, increased rate of perioperative bleeding, complication. B, decreased rate of restenosis. C,
let's say first one. Let's do first one by one. Correct or wrong? Rate of perioperative bleeding complications.
I think it has no relation between the bleeding. Yeah.
Unless you are a bad surgeon, you don't know how to do anastomosis, right? But if you're good, should not going to be the complications, So okay.
B, decreased rate of restenosis.
Is this correct?
Yes.
Yes, this is correct.
Yes, this is the one we talked about. Increased rate of surgical sites infections. I think in the neck has no relation with the infection, right?
No, nobody showed. This is what you think about it because you put a foreign body, but is rare, is very, very, very low. So it will not. No study showed this putting a patch to increase your site infection. No.
D, increase clamp time and rate of perioperative stroke. It does not increase, it decrease.
Yeah,
the stroke,
it may increase the clamp time. I think it will because it takes longer than do primary, but will not perioperative stroke. This is wrong, but it decreases it really. Some studies should decrease it. So this is wrong. Okay.
Decrease rate of perioperative bleeding complication. We said it has no relation.
There's no relation, so that's correct.
Mm.
Okay.
Uh,
So this is just straightforward. So always use a patch. All right, we'll go back. I got lost now. Whose turn? Amjad, I think, right?
Yes, yes. That's right.
Ah, Amjad. Oh, Crest, you like Crest trial. Let's go back to Crest trial. This is where
Okay.
they approve the carotid stent, correct?
Yeah.
And remember, Crest trial, they look at MI, stroke, and death, 3 things. And they found there's no difference between carotid endarterectomy and carotid stent, okay? So I'll tell you what this, let me see from the question. The Crest trial showed that if you do surgery, you see, if you put them all together, MI, stroke, and death the same, no different. But if you take each one by itself, you take the MI, they found that people who had the surgery has higher MI than stent. But if you look at the stroke, the people who has a stent have higher stroke than surgery. So if you go with surgery, you have higher chance of stroke MI. If you go with stent, you have higher chance of stroke. Okay. So what would you choose? What do you prefer to choose, stroke or MI? Because this is what I'm going to tell you.
No,
You're going to come to me. No, you can come to me. I'm going to tell you you have 2 surgery. Either I do carotid in surgery, but this increases your chance you may get MI, or I can do stent, but you may get a stroke, higher chance of stroke than surgery. So which one you choose?
I think MI.
Stent or surgery?
Surgery.
Why?
Because
But you get
decrease the
MI.
rate of the thing. But I want to treat, I want to prevent stroke or further stroke.
Yeah, but you get an MI. You see? You see, they look at that, they look at quality of life. The problem with the MI, with the CRIST, the cardiology, it was not really, it was an MI, but it was any troponin changes. They just went with the troponin. Patient may have no chest pain, just troponin level or EKG changes. So patient did not have a serious myocardial infarction, you know. So any change in troponin level or EEG, they call an MI, you know. So they look at the quality of life, the people who had an MI, and they look at quality of life, people who had a stroke. They found the quality of life is worse when you have a stroke than MI. The reason why, if you give you a choice, no, I prefer to have this subintimal MI than having a stroke, because when they did, as I said, when they did a lifelong follow-up, quality of life, they found people who had a stroke, they have a poor quality of life compared to people who had MI, okay? The reason why we still think that surgery is a standard, even increased chance of MI. But again, MI was not a real MI, what we see when patient comes to the ER and you have to rush him to the cath lab. No, this is just troponin level and EKG changes, okay? So you understand that?
Yeah, I get it.
You understand the trial, okay?
Yes.
So let's go one by one. So CREST has increased preventive mortality for carotid, but not for CAS. Mortality is they found is no different between both. There was difference between MI and stroke. Mortality is they found no different between both, you know?
Okay.
So this is wrong. Okay.
The increased risk of perioperative stroke for endarterectomy, but not for stent. I think the opposite, other way.
The opposite,
Stent is
correct.
more stroke.
Correct.
See a high composite risk of MI, stroke, and death for surgery.
No, it was the same. See, the composite was the same. When they put all together, it was no different. So it was the same. So it's no. So the composite risk, which is MI, stroke, and this was the same. So this is wrong. Okay.
Okay. An equivalent impact. An equivalent impact on quality of life compared to stroke and long-term follow-up. No, we said the quality of life difference between the two groups, stroke and MI.
It's better, right? It's they said equivalent impact. No, not equivalent. Like the stroke, they have a worse quality of life than MI.
MI,
so this is wrong. Okay.
Less impact on quality of life than stroke and long-term follow-up. Yes, I think this is the correct.
Yeah, this is the correct. This is very important, really, data to look at that, because they don't tell you, see, this is the small print as usually they said. You know, tell you, oh, it's the same, is no different. you know, but it's a different really. So, and if you have a choice between MI or stroke, I would choose MI. The reason why we still think the surgery is the best option for the patients, you know. All right.
Okay.
All right. Let's go back to Hamad. No, let's get Hamad some rest. Ahlam, you want to take next
Yes.
question?
Yes.
37. Okay.
64-year-old women present to the clinic with more than or equal 70% of the right internal carotid artery stenosis and left internal carotid artery occlusion by CTA. The vertebral arteries are patent. Contraindication to transcarotid artery revascularization is due to. So
Okay,
70% stenosis in the right and total occlusion of the left.
And then to the TCAR. Let's talk about TCAR because the whole question about TCAR, you know. Do you know what's TCAR, how they do it? What's the advantage? Ahlam?
No.
TCAR, this is a transcarotid, you see. The problem with the stent, as we said before, is a higher chance of stroke than surgery, even though we use a filter. So I said, why is that? And they found that most stroke happen when you cross the arch before you're able to put a filter. The reason why the stroke rate is higher than the surgery, because by the time you put a filter, you already crossed the arch. So if any disease in the arch will already embolize the brain and cause a stroke. The reason why they came with a new idea, I said, well, let's go directly to the common carotid. We just make a small incision in the neck. We go to the carotid directly, so we don't have to go through the arch. We put a filter, and then we do the carotid stent. So this is what's called a TCAR. And really, the result was excellent. Now the stroke rate went down exactly like surgery using a TCAR. But really, if you think about it, almost like a surgery, because you have to make a cut at the base of the neck. You have to expose the common carotid, get around it, cannulate it, and put a stent. So this is the downside of it. It's not like completely percutaneous. This is almost like you need a type of small surgery. But the good thing about this procedure, if you don't worry about the type of the arch. Like if you have a type 3 arch, you cannot do carotid stent because of the angulations. If you have a disease arch, if you have, you cannot do a stent. So this is a good alternative if patient like have a radiation, has redo neck, so you don't want to do a surgery, but at the same time you don't want to go through the arch, then this is a nice, procedure. And this now become very common procedure now called a TCAR. The only thing they don't use a filter in TCAR, they use a reverse flow. As I'm saying, it looks a bit complicated. So what happened is that they occlude the external and the common carotid artery. So the flow will go retrograde from the brain backwards. So when you dilate or stent the internal carotid, all the debris will go backward because now you reverse the flow. And this blood will go through the catheters, through a filter, and then after the filter, they push it back to the blood to the femoral vein. So it's a long catheter go to the femoral vein. Again, it looks a bit complicated, but this is the way the procedures, and people who do it quite often, they say it's not as complicated as it sounds, But in TCAR, they depend on the reverse flow. Okay, this is the way, because one way to protect the brain during the stent, either to put a filter or to use a reverse flow. And this is TCAR depend on the reverse flow. All right, so what they say now, what the contraindication, what situations you cannot use TCAR. Okay, let's see what they say.
First,
gender.
No,
it doesn't matter. Yeah, it doesn't matter, right, or male or female. It matters what the size, because the size of the artery, it has to be at least 5 and above. Because too small, you cannot put the common carotid, So yes, female, they have a smaller carotid than male, but it's not a gender, it's the size of the common carotid artery. So this is a wrong,
Yes.
Okay, what next?
The carotid bifurcation is greater than 5 centimeters superior to the clavicle. No, it's not contraindication.
Yeah, you need at least 5 centimeters. It's the opposite. Really, you need at least to be 5 and above. If it's the bifurcation close to the clavicle, there's no place to go there and do the dissection. Then become too short. Then it's better just do carotid endarterectomy. So you need at least to be 5 centimeters from the clavicle to the carotid bifurcation. So you have a space to go and put your sheath and everything, So this is wrong. If it's less, then yes, but this is greater, yeah.
Yeah, greater than 5. The contralateral carotid artery occlusion prevents adequate flow reversal. I think yes.
This is yes and no. Contralateral occlusions, usually when you have contralateral occlusion, really this is indication for stenting. Why? Because in stenting, you don't stop blood flow to the brain too much. You know, it's just like 5, you open the stent and that's it. Second, when you do a surgery, unless you use a shunt, you decrease the blood flow. So one of the indication for carotid stenting really is occlusion of contralateral artery, contralateral carotid artery occlusion, because they found the chance of stroke is less if you do stent than surgery. But the problem with the TCAR, they depend on the reverse flow. And for some reason, they found that even if you have contralateral carotid occlusion, if you do reverse flow, patient will not affect it. This is just from the studies, you know. So this will not be the right answer. No. Okay, so it's not a contraindication. So occlusion of contralateral carotid artery is not occlusion, not contraindication for TCAR. It's even sometimes it could be the indication for TCAR. Okay.
Yeah.
All right, next one.
The presence of a contralateral laryngeal nerve palsy.
This is tricky because contralateral nerve palsy is an indication for stenting. You see, the indication for stenting, one of them is contralateral carotid occlusion because you don't have to clamp, and contralateral laryngeal nerve palsy because the stent, you don't damage the laryngeal nerve. But in surgery, always the chance you can damage it. So you already have one contralateral nerve damage and you do surgery, you damage the other one, patient ends with tracheostomy. So one indication for carotid stenting if patient has contralateral laryngeal nerve palsy, okay? So this should be an indication really, but the problem with the TCAR is that it's different from carotid stent. You have to go to common carotid. When you go common carotid, behind it is what the vagus nerve. So there's always a chance, like a surgery, you can damage the vagus nerve. So really TCAR becomes like same indication for surgery. So if you have contralateral laryngeal nerve palsy, it's not good to do a TCAR. It's better to do a regular stent, carotid stent from femoral. Don't go through the carotid because you may damage the laryngeal nerve. The rest become like surgery. So in this situation, it is not better not to do it. So I think this would be the main contraindication not to do a TCAR. Okay.
The presence of patent left common femoral vein, no. It's not.
No, because I mean you want to be femoral vein to open so you can receive the blood when you do reverse flow. All right. So again, TCAR, it is very good. I mean, it is the same indication for carotid stent. The only thing is that if patient above 70, carotid stent is not indicated because you may get stroke from the arch, because people above 70, they have a disease arch. So they found the stroke rate is higher if patient above 70, then TCAR I think would be a good options. If you have patient above 70 or have a disease arch or type 3 arch, I think TCAR is a good option if you're not planning to do a surgery. Ipsilateral carotid occlusion and ipsilateral contralateral nerve palsy is indication for carotid stent, but not for TCAR because you don't want to damage the vagus nerve. All right. All right. Any question? No. All right. Well, let's go back to Dahman, Hamad.
مرحبا دكتور.
Hala. What is this question? Let's go to that one. Stent.
Okay. After stent deployment during transfemoral carotid artery stenting, the patient develops altered level of consciousness and hemiparesis on the contralateral side. Angiography revealed acute thrombosis of the internal carotid artery to the level of the filter. The next appropriate treatment, the next appropriate step in the management would be, so this patient has a thrombosed filter.
Okay, this is, by the way, it is common, not common, but you can get this problem. So you finish, you do an angiogram, you find no flow after the filter. So you know the filter full of thrombus, right? Or debris, you know? So what do you do now? Let's see what options you have.
So A, immediate conversion to open carotid endarterectomy.
Okay. Remember, there was this patient. Look at that one. You see, every time the question has something, you know? They said
transfemoral, and he had stroke. So
Okay.
I don't think this is the good, the correct answer. I can't treat it before.
The next step.
طيب.
Yeah, I think it could be one option, but it will not be my first option because they said what the next appropriate step. Doesn't mean that's
Next
the only.
appropriate
But
step,
this is
yeah.
yes. If you decide to open, you can do that. It's not a bad option, but it's not like my first approach. You know.
Yeah.
Well, let's see with the second one.
B, emergent transport to CT scanner for evaluation of the stroke and intracranial hemorrhage. I don't think we need to do that.
No, we already have a problem. We know what's the problem. We need a CAT scan. We know what's the issue. We know the problem. So I think wasting of time, this one would be. Okay.
Yes. C, continued systemic heparinization and transport to neurological intensive care unit for resuscitation. Also wrong.
Wrong, yeah.
I don't think
because you need to fix the problem. You already know the problem. And this is the best time to fix it now. Okay, so this is wrong. Okay.
D, immediate catheter directed administration of biximab, followed by administration of recombinant tissue plasminogen activator. I think this is the answer, right?
Yeah, because you need to have a clot. You need to remove it.
Yeah,
TBA,
thrombolysis. Yeah.
Is that we'll talk about this? Finish. What's the last one?
The last one is deployment of second stent up to the level of the filter with balloon angioplasty.
Okay, I mean, this is wrong. Well, how gonna put the stent? I mean, you have a clot. You're not gonna put more stent and you go higher and then go higher.
And you balloon
so
it also. Yeah.
Right. So this is wrong. So I think the best one is D, but doesn't mean this is the right answer. You know. I mean, when I trained with the carotid stenting, because I saw a couple of cases like that, you finish and put IFT. What happened is the filter fill up with the debris. The problem, if you think, you see, when you do a surgery, this debris is atheroma. It's not a clot, you know. So most of the time, TBA will not work. And there's no time for clot to form because patients are already hebronized, you know, you're doing a surgery, you know. So when the filter close, all the small close with debris, you know. So my teaching was that time is just the first thing, remove the filter and then repeat the angiogram. And most of the time, all the cases we did them, we found the arteries open up again, you know. So this is what usually we'll do. But you have to be careful. You see, when we do a filter, when you retrieve the filter, we don't retrieve it all the way because you have a catheter to retrieve the filter. We don't pull the filter all the way inside the catheter just to catch the tip. Because if you pull it all the way inside, all the small debris, it may squeeze outside and go to the brain. So we just catch the tip of the catheter and they remove the filter with the catheter all the way. And then will be the angiogram. If we still think, and the second thing, what we found could be a spasm from the filter. So this is also a reason why, you know. So it could be a filter or it could be a dissection. So it's not always like, you know, a thrombus. So the first thing is to remove the filter and do an angiogram and reassess your situation. If it's a dissection, you put a stent. If it's just a spasm, usually go back to normal. If it's like something clot all the way up, you go with TBA or you go and retrieve it, you know. But this is the way usually. But if you between this all option, I will choose D. But in practical, I think the first thing I remove the filter. But the only thing is that you have to. This is the advantage of the filter. What was we use it? The ambush shield. The key thing about ambush shield that the filter is not attached to the wire. So you can remove the filter and the wire is still there. So if you have any issue, any problem, you still have dissection, you have the wire, you can go over it and you can fix the dissection. Or the other filters, like you go with like spider filter or anything, the filter attached to the wire. So when you remove the filter, you're going to remove the wire. And then after you do an angiogram, you find you have a dissection or problem, then very hard to get the wire back, you know. So this is the reason why we always prefer to use the ambush shield filter. Even small, you know, headache is more difficult to use than other filters, but really like in this condition, it worked beautiful, okay? So again, and all these choices, I will choose D. But in real life, I will try to take the filter and then slowly again, and don't squeeze it completely and repeat the angiogram, and then you decide what to do. Because again, could be a dissection, could be a spasm, and could be a clot. Okay.
So D
All right.
is
D is the answer. For this
Yeah.
one, I think D is the right answer because all the
Yeah.
other is wrong, you know?
Yeah.
Yeah, you don't got to open because open will not help because the dissection distal, how's open will help, you know? So
Yeah.
mid converts to open is not because sometimes the problem is, usually the problem is high somewhere, either embolization or dissection. So it's away from surgical field, you know?
Yeah.
So open convert to open will not work and all other things is not a good options, you know? So I think D will be the best option for this one. Okay.
Yeah.
All right, let's go to Bassam, 39. Bassam.
Yes, yes, sir. A 68 years old man undergoes a successful carotid angioplasty and stent procedure for a 95% stenosis of right internal carotid artery. His left internal carotid artery is chronically occluded. Approximately 24 hours later, the patient complains of severe right-sided headache.
All right.
So this is hyperperfusion or reperfusion syndrome. Prevention
Right.
of cerebral hyperperfusion syndrome includes how to
Before we
prevent.
go to that, this is very important, guys. Anytime you do carotid endarterectomy, if patient the night develops severe headaches, you know, then you have to take that seriously, you know. Don't take the just headache, you know, after birth. You have to think about reperfusion injury. The problem is a reperfusion injury, you can't convert it to bleeding at any time. So if patient complain of headache after carotid, I usually send them for stat CT to rule out intracranial bleeding or hemorrhagic stroke, you know. So this is something, so anytime patient have a bad headaches, you know, take it seriously after carotid. When you see it, the reperfusion, if you have like the other side like occluded, and this side you do surgery about 90%, so the brain getting very few blood flow and suddenly increase blood flow to the brain, then this can get reperfusion injury. But you don't get it if you have like the other side is open, rarely you get it. So the other side has to be severely stenotic or occluded, and you reperfuse the other side, and then you get a reperfusion injury. How you correct it, as I said, severe headache and hypertension. You see blood pressure is very high usually. The most important, control blood pressure, because this is what converted from hyperperfusion syndrome to the bleeding, you know. So the most important to control the bleeding, blood pressure. So the first thing I'll do, I'll control blood pressure, get it down, you know, very close to the baseline, and get a head CT, and then go from there. But don't take it lightly after carotid surgery, patient has headache, or just give him Tylenol and that's it, you know. And you don't ask for blood pressure, and you need to rule out intracranial bleeding. Okay, so let's talk about that. Let's see what the options is, Sam.
Fluid restriction in the early postoperative period.
I don't think it will help much.
yeah.
I mean, you have a serious issue here, you know. I mean, this is, I don't think this will help. Continue.
Okay, supplemental oxygen to salvage cerebral tissue within the ischemic penumbra. Don't
Okay.
know what is this.
But ischemic penumbra is this is the area which, when you have a stroke, you have an area around it called ischemic penumbra. This is the area which is like you have a stroke. This area like demarcation.
Yes.
Like when you have a like you have an always when you have an ischemic tissue, you see like a black, and around it you see like something middle. So when you have ischemia, when you have a stroke, you see area of stroke, and around you see area which is like 50-50. This is called ischemic penumbra. This one is reversible. Stroke is not reversible. So when you see the stroke in the brain, it's non-reversible. But the area around it, the penumbra area, called it, it can be reversed. So yes, you give an oxygen and everything, you know, and try to increase blood perfusion to the brain. This may salvage this area. But this issue is not here. This is not the issue here. Our issue now is the ischemia itself, not the penumbra, is a stroke or hyperperfusion injury. Okay? Reason why this question is wrong. The answer wrong.
Okay. Use of dual antiplatelet therapy to minimize thrombosis in the ischemic penumbra. Okay.
No, that will not help.
Okay. Heparin infusion and permissive hypertension to salvage cerebral tissue within the ischemic penumbra. Aggressive postoperative blood pressure control to within 20 millimeter mercury of the preoperative level. So yeah, we usually we control the blood pressure post-op.
Yeah, again, I mean, the main issue here, Bassam, is that you don't want to convert it from, because you cannot do anything. This severe fusion injury, you already have an injury. So you don't think you don't want to convert it to the intracranial hemorrhage.
Yes.
Because if this happened, mortality almost 75 to 100%. So it's very high mortality.
Yes.
So what happened? You have an injured brain, a part of your brain is injured. Yes, I mean, all this will help, you know, fluid restriction, oxygen, but there's nothing. It's what you're going to convert to the bleeding is a blood pressure, because this is shit with a very high blood pressure. This is a sign of cerebral hyperperfusion. It's high blood pressure and severe headaches, you know. That's why they get a headache, because high blood pressure. So the first thing you need to control, like a dissection, look at that, like dissection. So the first thing you want to control blood pressure, you know, you want to decrease that, you don't want to convert it, because this thing will resolve by itself, you know. So the only thing you don't want to be converted to the intracranial hemorrhage or seizures, and patient die from that, you know. So the first thing is aggressive blood pressure control. So patient has to be to go to the like a dissection, has to be in ICU, and you put him, tell them to put him on a drip and bring blood pressure very close, within 20 millimeter of his preoperative levels, you know. So if his blood pressure before like 100, it has to be like within 110, 120, because his pressure will be like 180, 190, you know. So you need to bring, but you don't want to become hypotensive. Hypotensive is not good because decreased blood flow to the brain. So you don't want him to be hypotensive, like dissection. You just want him to get him back to the normal pressure within 20 millimeter, you know. So this is the best option, but you don't want him hypotensive also. This is bad, okay?
Yeah.
So this is, it's a practical, you may see it. So look at that seriously, understand the process, and try the most important to control blood pressure. Then you can do the other things. You can give oxygen, you control these things, but really what's going to make a difference is controlling blood pressure in this situation. Okay.
Okay.
All right. Who is going to finish this meeting? It's the best to the end. And this is who? Amjad,
Yes, Doctor.
going to be the end? The last
Yes.
one?
Yes.
All right, let's take this question.
An 81 years old diabetic woman with dyslipidemia, hypertension, and coronary artery disease has undergoing right carotid endarterectomy with prostatic patch angioplasty 3 years earlier. She now presents in follow-up for routine surveillance, duplex ultrasound, and CT angiograph. CT angiograph read the presence of 70% right internal artery stenosis. The characteristic that this describes this lesion is.
Okay.
So here.
So it's an 80 years old. She has carotid endarterectomy with a patch.
Yeah.
But even though within 3 years she came with a follow-up ultrasound, she's severe restenosis, you know.
Yes. Yes.
What's the nature history of restenosis? This is a benign or malignant, usually, the restenosis. You mean, is the course as the same as atheroma or is different course? Usually is more benign. The reason why this is an intimal hyperplasia, it's just nice and smooth, you know. It's not like atheroma, you see it like all this mushy material, ulceration, you know. This is just a nice, like your artery got restenosis, nice, smooth, intima. It's just because intimal hyperplasia causes stenosis, you know. The reason why the recommendation that if you have restenosis, is just leave it alone if a patient is asymptomatic, you know. But really, if symptomatic, you have to do it again. What you do it, what you can do, one of two options. There's no place for endarterectomy here because we don't have an intima problem here. Here is a fibro intimal hyperplasia.
Yeah.
So my new intimal hyperplasia. So the endarterectomy will not work here. So you have two options. Either you put a patch, just make it wider again, or you can use a stent, or you can resect this artery and put interposition vein graft. But the regular endarterectomy will not work in this one. And the same like when we see carotid stenosis after radiation, it's very similar pathology. Most of the time we don't do endarterectomy. Most of the time we just put a patch, you know. But in general, if you have to redo intercarotid, most of the time you're going to end putting just a patch without endarterectomy, or resect this part if it's very bad, very diseased, very stenotic, and put the machine graft. Or you do now, you would do a stent. It's very good. But this is only for symptomatic. Or if you have like a severe asymptomatic, like an 80% and above, some people, even if asymptomatic, they prefer to go and stent it or do a redo surgery. But this is controversial. But if symptomatic, 100% everyone agree, you have to redo it, okay? So let's go through the questions. What the incidence? What do you think the incidence? This is common or is uncommon? Restenosis after carotid surgery.
I think it's a common.
It's a common,
It's
yes,
common,
it is
yeah.
common. The other thing, we don't see it because we don't follow up all our patients for a long time. And the second thing is that because most are asymptomatic, but it's really common. It's about like 5 to 15%. So it is really common. So 3 to 5 is low. It's really higher. So it is a common problem. Yes. Next things.
Angiographic appearance is irregular and heterogeneous. No, we said different pathology than erythema.
Yeah, visual is nice and smooth, really. So this is wrong. Okay.
Risk of stroke is lower than de novo arthrosclerotic lesion. Yes.
Yes,
Different
because the lesion, as I
pathology.
said, because the nice and smooth.
Yeah.
So really,
Yeah.
it's not like atheroma and plaque and ulcerations. So really, the stroke is the reason why we think it's more benign. The reason why we are more reluctant to do surgery unless symptomatic or severe stenosis. But if you call the atheroma, it is different. It is, I think, the risk of stroke is lower. Yeah. Okay.
Likely initiated by surgical clamp site injury. I don't think it's related to the. Can be.
Yes, it can be. Is the reason why, if you see, when I finish the surgery after I pick the clamp, I always massage the common carotid artery. Some people who put a vessel loop and they tie it and then they release it, so that this one can cause an injury. So you really need to massage it. But the only thing why this is not right in this answer, usually this is, you see, when you see restenosis in any surgery within 3 months, is a technical issue. So if you see stenosis within 3 months of the surgery, this is either clamp injury, or could be the primary closure, or maybe you didn't complete endarterectomy, left part there, you know. So anything within 3 months is because there's no time for neo-intima hyperplasia in 3 months. Hyperplasia takes about 3 years, up to 3 years. It takes about 1, 2, 3 years. But anything within 3 months, they have to blame your surgical technique. So you do a surgery after 3 months, come patient with a high velocity, this is surgical issue. Either a clamp injury, or you didn't remove the plaque completely, or you miss it, or something like that. After 1 year, patient comes with a stenosis, then you think about neo-intimal hyperplasia. After 3 years, after 5, 6, 7 years, then you think about atheroma, because this is not the time neo-intimal hyperplasia already developed. So people still can get atheroma again, because if he has hypercholesterolemia, like this patient, she's high cholesterol, right? Dyslipidemia, they still can get atheroma again, but this takes longer time, more than 3 years. So within 3 months, technical, 3 months to 3 years, we say is a neo-intimal hyperplasia. 3 years and more, we think about atherosclerotic disease. Okay.
Okay.
Let's see what the last one.
Yeah. Primary closure has
closure.
similar risk of stenosis to batching. No, so the
No,
batching
we
is
think
superior
batching
to the
is
primary
better.
closure.
All
Yeah.
right, great. I think this is enough. And now at 40. So I think only 10 questions left. So hopefully next week will be the last session for carotid. We spent like almost 4 sessions for carotid, even though it looks like straightforward, but you'd be surprised how many things we have to know about it. All right, any question, guys, before we leave?
Yes, Doctor.
Yes.
For restenosis, Doctor, what is the best option? Like this patient, she had, yeah.
For this patient, I'll tell you, let's go back
repair.
to this patient. This one, baby, stenosis will be a stent. They didn't put this in one of the questions, but if they put it, I would choose a stent. I'll tell you why. Because at first it's restenosis, so you have chance of the nerve damage is higher if you do a surgery. So usually if you have a redo carotid, usually, where is that, sorry. If you have a restenosis after carotid surgery, even the guidelines said the best choice is to go with the surgery, with the stent, sorry, with the stent. And also she has coronary artery disease, dyslipidemia, hypertension. So she has a comorbidity, you know.
Okay.
Yeah, so I think I will go in general with the stent, you know, because
Right,
again,
so
redo surgery. Yeah.
So if it's young and it appears like in the first follow-up, post-op, what
This
to
is a
choose?
technical.
Yeah,
Then I have to do CT angiogram and there'll be surgery to redo it because technical issues. Then I have to
redo.
redo, maybe took the patch and fix it, or I'll not put a stent, you know. Even
Yeah.
redo young, but it's ready to redo young because it takes long time. And this is not a young patient's, you know, disease. But anyway, if young people or within 3 months, if they come back 3 months, unless if it's high risk for surgery for some reason or high bifurcation, or my surgery complicated with the nerve damage, I don't want to do more damage or something like that, or has occluded contralateral ICA. So anything, you know, but my first choice will be a surgery. Second choice would be stent. But
Great.
in old people, my first choice will be stent. Yes.
Okay.
Age will not be contraindicated.
The
for
question
stent in
is,
this
do we
age.
need to put the question really? Do we need to put a filter or not? In my opinion, you don't need it because different pathology. But the problem, we don't have any data to support that. So I'll use a filter. But in my deep in my heart, I don't think we need to do it because this is a new intimate hyperplasia. You just need to dilate and put a stent. It's not going to break loose like when you do the atheroma. But so when I redo, so I put a filter, but for some reason, if you cannot put a filter, it's very difficult to have a problems. I think you can do it without a filter. But don't tell anybody I told you that. But the problem, we are recording now. we are on record now. All right. Anyway, what else? Amjad, you were talking?
Yeah, I was asking, stenting in restenosis in old people and the age, it will not be contraindicated?
Yes. Above 70, we don't like to do it if they have a bad arch. But again, nothing in medicine like white and black. I mean, you have to wait and, you know, risk and benefit. If the arch is fine and straightforward, I will go with that. If the arch is bad, I go do a TCAR. I go right away to carotid. Still, I think better than surgery. So again, to have to case by case, you cannot generalize everything. You have to look at the patient, decide what the best options. But the most important to understand what the pathology, what pathology you're dealing with it, you know. So again, I mean, if his first surgery was, you know, complicated or difficult, you read the history. If he's your patient, you know, if it was straightforward, you can go again. I mean, redo is not very bad, really. It's not very bad as people expected, you know. It's especially you're going to do just go and put a patch, so it's not difficult. But stenting is not a bad option in this 81 years old. If the arch is fine, I'll do it. If the arch is disease, I'll just go right away to the TCAR. Okay.
Nice, yeah.
Any more questions? All right, guys, enjoy the rest of the day and we'll see you next week.
Thank you so much.
You take care. Take care. Bye-bye.
Thank you very much.
شكرا الله يعافيك.
Yeah.